I'm Anne-Marie Gregorian. I'm the medical director for the ECLS program at the Hospital for Sick Children at the University of Toronto. I'd like to thank the virtual ELSO organizers for inviting me to present with Dr. Mark Davidson, and thank you to Dr. DiNardo, our chair, for organizing this debate. So I'll be presenting the pro side of all pediatric patients with cardiac arrest should be considered for eCPR. My disclosures is that ECMO products used in children in Canada are used by a special access program from Health Canada, and I volunteer for organizations that review the evidence related to eCPR. So what's the eCPR definition? It's the rapid deployment of ECMO or cardiopulmonary bypass to provide reperfusion with oxygenation, decarboxylation, and cardiovascular support in the context of cardiopulmonary arrest. eCPR is defined when ECMO flow is instituted during conventional CPR or within 20 minutes of return of circulation without ongoing compressions. So this is the schematic that we're going to use throughout the session. So there's an event, there's a cardiopulmonary arrest that may involve then receiving CPR, and ultimately there's a decision to add ECMO for reperfusion and return of circulation. So the reasons that I like to consider for adding eCPR to CPR in children are that conventional CPR works, but is imperfect in certain circumstances. High quality CPR is necessary, but may be insufficient depending on the patient. Cardiac arrest occurs in patients in settings that are suited for eCPR in 2021. And post-cardiac arrest syndrome requires post-cardiac arrest care that may be superior with ECMO. I could also just close my statements by saying that there are pediatric eCPR guidelines from 2020 and 2021 that allow clinicians to make decisions and consider this technology in the context of CPR. But I'm going to give you examples. And one of the first example is a 3.5 kilo, 10-day-old infant with congenital heart disease and single ventricle, and who's in the cardiac intensive care unit, intubated with a rising lactate above 10, and has low cardiac output syndrome post-surgery after a stage 1 palliation with Norwood type surgery. And 8 hours after his surgery, his low cardiac output syndrome evolves and worsens, and he develops cardiopulmonary arrest. And I would advocate that the team should not only be ready for CPR, but should also be ready to institute eCPR. The second example is a 4-year-old intubated with myocarditis who's also already in the cardiac intensive care unit, develops arrhythmias refractory to medications and repeated defibrillations, and ultimately has a malignant arrhythmia that evolves to PEA and cardiopulmonary arrest. And I'm going to advocate that the team should not only be ready for compressions and traditional CPR, but they should be ready to add eCPR. Another example is a 4-kilo neonate who's 2 days old, who's being treated for meconium aspiration and PPHN, who's hypoxemic, hypotensive, acidotic, despite mechanical ventilation, INO, inotropes, and vasoactive agents, and who develops a pneumothorax and deteriorates to cardiopulmonary arrest. And again, in this child, I think the team should be ready not only to institute cardiopulmonary arrest, but should be ready to add eCPR. And the fourth example is an 8-year-old with sickle cell disease and chest crisis and strep A pneumonia and empyema. She's in the PICU and has severe septic shock and hypoxemia. And during the stabilization and preparation for the erythrophoresis or exchange red cell transfusion, she deteriorates and develops cardiopulmonary arrest. And in this patient also, there should be anticipatory vision that this patient might deteriorate, and the team should be ready to add eCPR. So if we get back to what eCPR is and provides, if we go back in time with history and pioneers and heroes of mine, Peter Safar and Mark McMahon in Baltimore published some of the first reports about artificial mouth-to-airway emergency use in 1958. And interestingly, if you find the papers, they did report it in the method in a 9-year-old child. And then we've got Kuvenhoven, Jude, and Knickerbocker, who were working down the road in Baltimore also at the same period on a model of defibrillation in animals and came upon the use of chest compression during their experiments and ultimately published closed chest massage and defibrillation, but that was for the type of arrest that occurred with fibrillation at its outset. All these individuals came together eventually in Baltimore and invented the early times of CPR, and we should be very thankful. The key that's changed is that in 2021, the epidemiology of pediatric cardiopulmonary arrest is really an inpatient condition. And whether you look at the UK recent paper that looked at the multi-center aspects of pediatric ICU cardiopulmonary arrest, or the data that comes from the United States from a large hospital-based registry that reported in the recent couple of years several trends on in-hospital cardiopulmonary arrest, night and weekends, and even in-hospital defibrillation. The pediatric cardiopulmonary arrest phenotype is an in-hospital event. It's monitored, and the great majority is in the intensive care unit setting, and often has an airway already in place. It's in high-risk populations. We've also understood that the younger child is more involved epidemiologically in hospital cardiopulmonary arrest. It's a post-operative also risk state, and it happens early after admission to the intensive care unit. So if we try to categorize or classify these cardiopulmonary arrest events, again, a little bit more, there are pulseless events and there are bradycardia and poor perfusion. And I'll focus on the pulseless events. If we try to come back to the early days of CPR and their defibrillation capacity or amenable to defibrillation, when we look at the pediatric epidemiology, pulses, shockable rhythms are very rare in pediatrics. And whether it was the report that was in the early 2000s or the most recent report by Dr. Hunt that covered 15 years, less than 10% of pediatric in-hospital pulseless events were shockable. So if we focus also on how CPR, even if delivered, is imperfect, prospective study of 139 CPR events reported that across, and this was prospectively evaluated across 7 large PICUs in the US, 22% did not even attain ROSC with CPR only. Ultimately, if they had ROSC, 64% survived at 24 hours, but you can see that there's a huge drop-off of almost 20% because 45% survived to hospital discharge, and there's a large rate that die from withdrawal of life-sustaining therapies, and we assume it's because that the impact of reperfusion may not have been positive. We see in a larger report, again, from the Get With the Guidelines registry published very recently by Holmberg and authors, that 32% of survival to hospital discharges reported from pulseless events in pediatrics, and that while there was an increase in the rate of survival up to 2010, that rate has plateaus in the last 10 years. So high-quality CPR is important, but may be insufficient depending on the patient's underlying physiology that may not be amenable to be optimal with conventional CPR. The patient's functional reserve at the time will not respond to conventional CPR, and the cause of the event is not immediately reversible with conventional CPR. So in hospital cardiac arrest in patients with cardiac disease, eCPR may be considered for reversible conditions when physiology and functional parameters of the underlying patient may limit the effectiveness of conventional CPR. And the first example of the single ventricle patient is a good example of that. Dr. Ortman and colleagues reported that the survival to hospital discharge in children with cardiac disease was actually different than patients with non-cardiac disease, but still among the cardiac disease, if they looked at the use of eCPR versus conventional CPR, the odds of survival were more favorable and higher in both surgical cardiac disease and in medical cardiac disease. A different study tried to evaluate and compare conventional CPR to eCPR in the Get With the Guidelines registries, and they did, Dr. Javi Lassa and his colleagues did report that both the survival and the survival were with favorable outcomes was higher in patients exposed to ECPR. And when they evaluated adjustments of different confounding factors, either with traditional regression or propensity matching, they also found that ECPR had a higher odds of hospital discharge and a higher odds of favorable neurological outcome compared to compression and conventional CPR. If you put these studies together, you end up with a pooled estimate and a systematic review that shows that ECPR is favorable compared to conventional CPR. So the ELSO registry has diligently allowed volunteer reporting of ECPR cases since the early 90s, and there's been a sustained survival to hospital discharge that's greater than 40% since 2008. What this also shows you is that I would say in the last 5 years, there's been a significant increase in the use of ECPR. In a very recent observational systematic review published by Dr. Fahad and Lakshmi Raman and colleagues, report that when you bring all these observational studies together, 46% of survival is the pooled estimate that they generated for ECPR patients, and 30% of survival with favorable outcomes. So it brings us to refocus on patient selection and setting in systems. So in the 4 examples that I gave you, there was opportunity for patient suitability to be assessed as suitable, yes. The patients were expected to benefit from ECPR over CPR only, yes. The events were witnessed. They were all in the intensive care unit. The cause was reversible. And the anticipation was that if conventional CPR delivered with high quality was not sufficient, ECPR could be delivered. We have a system at Sick Kids that allows us to review the physiology before, during, and after cardiopulmonary arrest, and that's led by Dr. Madeline Burdick and Dr. Michael Alice-Moga, who's one of our cardiac intensivists. And they review in detail the physiology and all the interventions delivered. And if you focus on the blue or aqua CPR bar, you'll see that this event was a prolonged event where we didn't initiate ECPR, but a lot of interventions had to be delivered and medications ultimately to obtain return of spontaneous circulation. In this patient in whom ECPR was planned and potentially anticipated in the context of a deterioration, after a short period of conventional CPR, ECPR was launched and the patient was able to have return of circulation with mechanical support. And we're also trying to consider what happens in the post-cardiac arrest care, and just the glimpse gives you a sense that the physiology was improved. So it brings me to summarize also briefly that post-cardiac arrest care can occasionally be better delivered with ECMO support because it allows the oxygenation and decarboxylation to be dialed in with the hemodynamic targets and the temperature targets, whether it's normothermia or hypothermia. It allows us to potentially stop some of the harmful high mechanical ventilator pressures that may impair the patient's physiology after cardiac arrest, and it allows us to stop repeated pharmacological exposure of agents that may be harmful at the phase of ischemia. So ECMO post-cardiac arrest care phases can be adapted from the post-cardiac arrest care phases that were suggested by the American Heart Association statement led by Dr. Tabjian, and it allows still for diagnostics, therapeutics, imaging, and a transition off of ECMO to continue for post-cardiac arrest care without ECMO. So in the example 1, I'm going to say that yes, ultimately a bridge to recovery with ECPR is suitable, and the recovery can occur within 7 or 8 days. Given the fact that this is a patient with a single ventricle, when patients have a potential or anticipated to potentially deteriorate, they have a cannulation strategy that's tailored to their individualized functional anatomy. And in this case, this was also with an open sternum. For the second case, the ECPR was used because the patient's ability to benefit from conventional CPR was exhausted at the time of the event, and the patient can either be bridged to recovery or to another device. For patients who have cardiopulmonary arrest without cardiac disease, the guidelines suggest that when extracorporeal measures are part of a predefined CPR plan where conventional CPR is not expected to be effective, the events are witnessed, and there's a reversible cause, it can be considered. And I'm going to say that in the third example that I gave you with the neonate with PPHN, he was ultimately had been identified as potentially being a candidate for standard VA ECMO, and because he deteriorated before that time, it was reasonable to consider ECPR as part of his CPR plan. It also allowed to decrease the interventions that may be prohibiting his pulmonary vascular resistance to decrease. We were able to support his RV, his LV, and decrease the high mechanical ventilation pressures and inotropes. For the fourth example, ECPR and then ECMO post-cardiac arrest care allowed for the oxygenation, the normalization of the metabolic state of this patient with sickle cell to be immediately addressed. There was a safe transfusion exchange that could be done through the ECMO circuit, and there was a decrease in the mechanical ventilation that allowed for the RV and the LV support to be better recovered in the context of sepsis. So the timing of this ECPR, each institution is different, and usually the decision needs to be done with I would say, a high qualified staff physician who will understand both the patient characteristics and the intervals of time that are required to initiate and deploy the team and cannulate the patient. So depending on the organization, some may need to call earlier rather than later. We at Sick Kids know that we need to be able to call and make our decision within 7 to 10 minutes to be cannulated. Within our benchmark is a total time to blood flow 30 minutes. We know we don't always get there, and we work and we try to understand with regular reviews and our performance improvement process to improve the different intervals that are required to transition from cardiopulmonary resuscitation measures that are conventional into an ECPR measure. It requires high quality, I would say, team training, simulation, and also an organized set of protocols with roles and responsibilities that need to be understood and practiced. So high quality ECPR is possible with high quality CPR, decision making, and high quality ECMO performing systems with adequate patient selection, predefined institutional protocol, and organized system. It's an approach that can enhance CPR measures. And I'd like to thank my co-authors of the ELSO guidelines, who were absolutely delightful to work with and to generate the most recent guidelines. Thank you.
Thank you, Anna-Marie. Great presentation. And now we have, for the contrary, my friend and colleague Mark Davidson from the Paedratric Intensive Care Unit of Glasgow. Mark is director of the ECMO program